Okay, imagine this. You've been in some fresh water, maybe traveling, maybe just, waiting somewhere, and then you feel it, that tingling, that itch. Swimmer's itch, people call it. Seems pretty minor.
Mm.
But what if it's actually the first clue, the sign of something much bigger, a condition known globally as Bilharzia?
Welcome to this deep dive.
Yes, welcome. And this one, it's really built around the notes you've shared with us on schistosomiasis, also known as Bilharzia, sometimes Katayama fever. Our mission today is to take all that information you've gathered and really turn it into a conversation that's high yield, easy to follow.
Exactly. We're going to unpack the key points directly from your source material, structure it logically, make those complex details clear and hopefully memorable. Whether you're actively revising or just trying to get a solid grasp of this condition quickly.
Think of it as us navigating your notes together, pulling out the absolute must-know facts.
We'll cover everything outlined from the basic definition right through to complications in management.
All right, let's jump in then.
Let's do it, starting right at the beginning.
Okay, so let's unpack this. Based on your notes, what exactly is schistosomiasis at its core?
Well, fundamentally, it's a parasitic infection. Your notes are clear it's caused by trematode worms, specifically from the Schistosoma genus.
Right. And the big one, how do people actually get it? How does it, get inside?
The key, according to the notes, is direct contact with contaminated fresh water. And it's not just about drinking it.
Whoa, okay.
No, things like swimming, wading, and even bathing or washing clothes in water where these parasites live. That's enough for infection.
Got it. And the notes mention those other names, Bilharzia, Katayama fever, and that swimmer's itch thing we mentioned.
Yeah.
Good to keep those synonyms in mind, I guess, especially for revision.
Absolutely. They all recur to the same condition. And it's really crucial, as your notes point out, that different species of schistosoma exist and they affect the body differently.
Oh.
The notes specifically highlight Schistosoma haematobium. Now, this one is particularly important because it tends to deposit its eggs in the bladder. And that leads to inflammation, calcification of the bladder wall. It can cause obstructive uropathy, so blocking urine flow, kidney damage, and importantly, a significantly increased risk of squamous cell bladder cancer.
Wow, that specific link, S. haematobium and bladder cancer, that feels like a key takeaway from the notes.
It's definitely a high-yield point.
So anytime you see those names, or especially that species cancer connection, you know we're talking about this specific parasitic worm infection from freshwater contact.
Exactly. So now let's get into the origin story, the etiology and the transmission cycle that your notes describe.
Right. The what is the worm, but the how. How does it actually complete its journey? How does it get from person to person, essentially?
Well, the notes detail this really interesting multi-stage life cycle. It starts with infected humans releasing the parasite's eggs into fresh water, usually through urine or feces.
Okay, which immediately flags up that risk factor of poor sanitation mentioned later in the notes. Makes sense.
Precisely. So once in the water, these eggs hatch. They release something called miracidia.
Miracidia.
Okay, these are free-swimming larvae, and their job is to find and penetrate a specific type of freshwater snail. The snail is absolutely critical here. Your notes identify it as the intermediate host.
Right, the intermediate host. And inside the snail, it's not just hanging out, right? Something else happens.
That's right. The parasite undergoes development and multiplication within the snail. Then it's released back into the water, but in a different form as cercariae.
Cercariae? Okay, is that the stage that infects humans?
Yes, your notes specify this is the infective stage for humans. These cercariae are tiny, fork-tailed larvae. They swim freely, and they can actively penetrate intact human skin upon contact.
Wow, straight through the skin. So it's this cycle. Human sheds eggs into water. Eggs hatch, larvae infect snails.
Yeah.
Develop in snails, release new larvae back into water.
The cercariae.
And those cercariae penetrate human skin. Wow. And the notes also mention animals can sometimes be reservoirs, too, for some species.
Yes, adding another layer of complexity to control efforts in some areas.
So, given that whole cycle, the risk factors listed in your notes start to seem pretty logical. What stood out to you there?
Well, the most obvious, as you'd expect, is geography. Living in or traveling to endemic areas where the parasite and the necessary snails are present.
Right.
And fundamentally, any activity that involves exposure to potentially contaminated freshwater in those regions.
Makes sense.
Your notes also flag up factors like poor sanitation, which helps the eggs get into the water in the first place. And things like lack of protective clothing or safe water sources during activities like farming, fishing, or just daily chores that involve water contact. It's really about the intersection of the parasite's biology, human behavior, and environmental conditions.
So you need to think about places where all those factors come together. That's where the risk is highest.
Exactly. Now let's dive a bit deeper into the pathophysiology section of your notes. What actually happens inside the body after those cercariae get through the skin?
Okay, so they penetrate and then they don't stay as cercariae, do they? They change.
Correct. They transform into schistosomuli. Then they migrate through the body, eventually mature into adult male and female worms, and they pair up and settle in specific blood vessels, usually around the intestines or the bladder, depending on the species.
And is that when the symptoms start? When the adult worms are there?
Well, this is where it gets interesting. The adult worms themselves cause some issues, but your sources really emphasize that the eggs produced by the female worms are the primary cause of the disease, the pathology, the symptom.
Wait, the eggs, not the worms living inside you. That seems counterintuitive.
It does, but that's a key insight from your notes. What happens is many eggs don't get passed out of the body. They get trapped in tissues, the liver, the bladder wall, the intestines, sometimes even the lungs or brain.
Okay.
And the body mounts a really strong inflammatory immune response against these trapped eggs. It forms granulomas around them. Your notes describe this granulomatous response as the major driver of the morbidity, the illness associated with chronic schistosomiasis.
So it's less the worm itself causing direct damage and more the body's own kind of over-the-top reaction to the eggs?
Largely, yes. That inflammatory response leads to tissue damage, scarring, fibrosis over time, and of course some eggs do manage to get excreted in urine or feces, which is how the cycle continues.
That's fascinating. Okay, shifting gears slightly, let's look at the scale of this problem. The epidemiology notes you provided paint quite a picture.
They really do. The numbers are stark. Your notes mention approximately 240 million people affected worldwide.
240 million.
And over 700 million living in endemic areas, meaning they're at risk of infection.
That's staggering. I mean, this isn't some rare, obscure disease. It's a huge global health issue.
Absolutely. And it's concentrated, as we'd expect, in tropical and subtropical regions, very closely linked, as your notes highlight, to communities lacking adequate sanitation and safe water supplies, tying back directly to those risk factors. The notes also reiterate that point about different species causing different main forms of the disease, urogenital schistosomiasis, primarily from S. haematobium in Africa and the Middle East.
Right, the bladder one.
And intestinal schistosomiasis, mainly from S. mansoni and S. japonicum, found in Africa, South America, and parts of Asia.
Okay, so knowing the geography of exposure can give you a clue about which type you might be dealing with. Now, what would someone actually feel? What are the symptoms? Your notes break down the clinical presentation by stage.
Yes, the symptoms are really variable. Depends on the stage of infection, the species involved, the number of worms, and which organs are most affected by the eggs. The notes distinguish between acute and chronic phases.
Let's take acute first. That happens pretty soon after getting infected.
Correct. Typically seen in people who haven't been exposed before, like travelers visiting an endemic area. First, you might get that transient swimmer's itch, a rash right where the cercariae entered the skin. Then, maybe a few weeks later, they could develop Katayama fever. Your notes describe this as a systemic hypersensitivity reaction. Symptoms include fever, chills, muscle aches, joint pain, cough, diarrhea, sometimes a hives-like rash.
This sounds like a bad flu, almost.
It can mimic many things. And importantly, the notes mention eosinophilia, a high level of eosinophils, a type of white blood cell in the blood. That's a key lab finding we'll come back to, but it's characteristic of this acute phase.
Right. And then the chronic phase, that develops later on.
Yes, this can develop months or even years after the initial infection, especially with ongoing exposure. Yeah. This is really due to that chronic inflammation caused by the trapped eggs.
And the symptoms depend on where the eggs are.
Exactly. Your notes list things like persistent abdominal pain, chronic or bloody diarrhea if it's mainly intestinal, blood in the urine, or haematuria, which is the classic sign of S. haematobium infection affecting the bladder. Also, enlargement of the liver and spleen hepatosplenomegaly due to eggs lodging there. Chronic fatigue is common, and if eggs travel to the lungs, you can get pulmonary symptoms.
And in really severe long-standing cases, the notes mention some pretty serious signs.
Yes, Things like abdominal tenderness, sites that's fluid building up in the abdomen, usually due to the liver damage and portal hypertension, and even altered mental state if eggs reach the central nervous system, although that's less common. These point towards advanced, complicated disease.
Okay, so someone comes in, maybe with fever, maybe tummy problems, enlarged liver or spleen, possibly they mentioned travel or water exposure. What else could this be? How do your notes guide differentiating it?
Well, the differential diagnosis section in your notes is quite brief. It basically says to consider other causes for those key symptoms, fever, hepatosplenomegaly, gastrointestinal issues, which I suppose raises the point that because the symptoms can be so varied and nonspecific, that history is absolutely critical. History of travel to an endemic area, history of freshwater exposure there. That's what should really make you think specifically about schistosomiasis amongst, a potentially broad list of other possibilities.
Makes sense. History is key. So how do we actually confirm it then? What do the notes say about investigations?
Your notes clearly state the gold standard for diagnosis,
And that is.
microscopy, looking for the schistosome eggs in stool or urine samples. Which sample you check depends on the suspected species. As we discussed, urine for S. haematobium, stool for the intestinal types like S. mansoni or S. japonicum. Seeing those characteristic eggs under the microscope confirms an active infection.
Okay, gold standard is finding the eggs. But what if it's early days, maybe that acute Katayama fever stage, or someone just has a very low number of worms and isn't shedding many eggs? Are there other tests listed?
Yes, the notes mention serology for those situations. That means looking for antibodies or antigens related to the parasite in the blood. It can be useful for diagnosing infections in people who haven't built up a high egg load yet, or for travelers returning from endemic areas. It shows exposure.
But it might stay positive even after treatment, right?
So that's a key limitation to remember, yes.
Yeah.
It indicates exposure past or present.
Okay. What about other lab tests mentioned in the notes?
Your notes list a complete blood count, or CBC, specifically looking for that eosinophilia we talked about, especially in the acute phase,
Right.
or checking for anemia, which can result from chronic blood loss, either from the gut or the bladder. Assessing kidney function, renal function tests is also important, particularly if you suspect S. haematobium because of that risk of kidney damage.
And imaging. Or any procedures.
Several are listed as potentially useful depending on the situation. Ultrasound can assess organ damage, like the size of the liver and spleen, or signs of fibrosis or portal hypertension.
Okay.
An ECG or chest x-ray might be needed if pulmonary complications are suspected. MRI or CT scans are used if there's concern about CNS involvement. A plain x-ray of the pelvis can sometimes show calcification of the bladder wall that's quite specific for chronic S. haematobium. And then endoscopy or cystoscopy allows direct visualization of lesions in the bowel or bladder lining.
So, if I'm trying to remember this for revision, microscopy, gold standard, find the eggs. Serology, helpful for early infection or travelers. Other labs like CBC and renal function, check for common issues like eosinophilia, anemia, kidney impact. And imaging, assess organ damage and complications.
That's a pretty good summary of what your notes cover for investigations.
Okay, so we've found it. We've diagnosed schistosomiasis. How do we treat it, according to your notes?
The mainstay of treatment, clearly highlighted in your notes, is the drug praziquantel. It's listed as the first choice medication.
Praziquantel.
Yes. It's effective against all species of schistosoma. It's generally safe, including in pregnancy, according to WHO guidelines, and it's often given as a single oral dose, or sometimes spaced doses, depending on the context.
A single dose. That sounds quite efficient, especially for public health programs.
Exactly. Its ease of administration and efficacy make it the cornerstone of mass drug administration, or MDA, programs in endemic areas. Your notes also mention another drug, oxaliplatin, as an alternative effective against S. mansoni, but praziquantel is really the primary drug used globally now.
What about emergencies? Are there specific emergency management points in the notes?
Yes, the notes state that emergency management is needed for acute complications. The specific example given is managing severe intestinal bleeding, perhaps from ruptured varices caused by liver damage. That would require urgent intervention.
And surgery. Is that ever needed?
It's mentioned for specific, usually chronic complications. For instance, endoscopy with sclerotherapy, or banding for bleeding esophageal varices, those swollen veins in the esophagus due to portal hypertension from liver scarring. Also, surgical shunt procedures might be considered for severe portal hypertension in some cases. And the notes mention corticosteroids, or sometimes surgery for cerebral schistosomiasis, dealing with the inflammation around eggs in the brain.
And the notes also briefly touch on the UK context again.
Yes, just reinforcing that in non-endemic settings like the UK, the focus is primarily on diagnosing and treating imported cases found in travelers or migrants coming from areas where schistosomiasis is common.
Okay. So, key message for treatment. Praziquantel is the go-to drug.
Definitely the name to remember.
All right, what about stopping it before it starts? Prevention. Can we prevent this? What do the notes say?
Well, one very clear point from your notes is that currently there is no vaccine available for schistosomiasis.
No vaccine. Okay, so control has to rely on other methods then.
Exactly. The main strategies listed in your notes focus on breaking that life cycle we discussed.
Makes sense.
Firstly, mass drug administration with praziquantel. Treating whole communities or high-risk groups, like school-age children in endemic areas, helps reduce the overall burden of infection and the number of eggs being shed into the environment. This is sometimes called preventive chemotherapy.
Okay, treat people to reduce spread. What else?
The other key pillars mentioned are providing safe water supplies so people don't have to use contaminated sources for drinking, washing, or bathing, improving sanitation to prevent eggs from reaching water bodies, and implementing snail control programs to target that crucial intermediate host.
So drugs, clean water, sanitation, and tackling the snails. A multi-pronged approach.
It has to be, given the complexity of the cycle.
Now, what about the long-term outlook? If someone gets treated, what's the prognosis? What do your notes suggest?
The notes emphasize that if schistosomiasis is diagnosed and treated early, before significant organ damage has occurred, the prognosis is generally good. Treatment can halt the progression and often reverse some early changes.
That's good news. But what if it's chronic, it's been missed, or left untreated for a long time?
That's where the outlook becomes much more serious, and the prognosis worsens considerably. Your notes link chronic, untreated infection directly to the development of those severe complications we touched upon.
Right, the long-term damage.
Yes. Things like irreversible liver fibrosis leading to portal hypertension and its consequences, severe bladder damage and obstruction, kidney failure.
And sadly, it can even be fatal, can't it?
Unfortunately, yes. Your notes provide a statistic estimating that approximately 14,000 deaths per year are directly related to schistosomiasis, mainly due to those chronic complications.
14,000 deaths. Okay, so let's just circle back and explicitly list those complications again, as detailed in your notes. The potential long-term problems that make early treatment so vital.
Yes, let's summarize those. Chronic schistosomiasis resulting from that persistent inflammation around trapped eggs can lead to significant organ damage. Your notes clearly list severe liver fibrosis, scarring of the liver, which can lead to portal hypertension, enlarged spleen, ascites, and esophageal varices. Then there's bladder wall fibrosis, calcification, potential obstruction of the urinary tract, hydronephrosis, and chronic kidney damage, eventually kidney failure.
And that specific cancer link again?
Yes, the significantly increased risk of squamous cell carcinoma of the bladder, particularly associated with chronic S. haematobium infection. That's a major one.
What other issues are listed as complications?
Also mentioned are chronic gastrointestinal problems like bleeding, malabsorption, difficulty absorbing nutrients, which can lead to malnutrition and stunted growth, especially in children, and potentially an increased susceptibility to other infections because of the chronic inflammatory state or organ damage.
And there was a point in the notes about co-infections.
Yes, a very important point. The notes specifically mentioned that outcomes can be worsened if someone with schistosomiasis is also co-infected with other major diseases common in the same areas, like hepatitis B or C, HIV, or malaria. It highlights the complex interplay of health issues in many regions.
Wow. Okay, we have really gone through your notes from start to finish there. From that initial contact with water, the swimmer's itch, all the way through that intricate life cycle, the global impact, the mechanisms of damage to those eggs, how we diagnose it, the importance of praziquantel for treatment, and then those really serious potential long-term complications if it's not managed.
We've really extracted the core information points directly from the source material you provided, hitting all those key sections vital for understanding or revising schistosomiasis.
Hopefully breaking it down like this, piece by piece, makes those notes feel a bit more connected and less overwhelming. You can sort of see the whole story now.
And if you think back to that life cycle, human, water, snail, water, human, that narrative really holds it all together. It explains the risk factors, why sanitation and water safety are key for prevention, why snail control matters, and how the parasite actually causes disease inside the body.
Definitely. And maybe a final thought to leave you with, based on everything we've discussed from your notes. Schistosomiasis as a disease really depends on a specific intersection of environment, biology, and human behavior.
Hmm.
The fact that it persists on such a massive global scale, even though we have an effective treatment like praziquantel and we understand how to prevent it, really highlights the profound impact of broader factors. Things like poverty, access to clean water, sanitation infrastructure, how deeply interconnected these are with health outcomes worldwide. What does the persistence of this one parasitic disease tell us about tackling global health challenges more broadly? Something to think about.
So that wraps up another deep dive. We genuinely hope this session has been high yield for you, helping to clarify and solidify your understanding of schistosomiasis based on your own notes.
Yeah, absolutely. Nailing down complex topics like this point by point is just so crucial, whether you're in the middle of revision or just building up your clinical knowledge base.
And if you are revising, particularly for the MSRA, and looking for more resources,
Right. You can check out pastemsra.com.
and also freemsra.com.
Yeah, both sites have a ton of practice questions, mocks, and other materials designed specifically to help you prepare and feel confident. So, pastemsra.com and freemsra.com.
Thanks for joining us for this deep dive into your notes on schistosomiasis.
We really enjoyed working through this topic with you.